that this morning. Someone wanted to go advanced first, but he must be an overachiever.
Yeah.
We're going to go ahead and start with basic. We're going to talk about the anatomy and physiology of the respiratory system. That's the foundation of this. If you don't understand how it works, then you don't know how to treat it. We're going to talk about what regulates respirations, how to measure respiratory function, and is your patient actually having adequate function. We'll talk about respiratory problems, the assessment of the respiratory system, and some non-invasive monitoring systems that you guys will be using. Am I loud enough? Can everyone hear me?
Yeah.
So, functions of the respiratory system. You guys alluded to it a few minutes ago. The main function is gas exchange. It brings oxygen into our body for our cells to use in our tissues, and exchanges CO2. That happens all in the lungs. If we don't get rid of our carbon dioxide, our bodies get acidotic and we die. If we don't get oxygen, we get anoxic and we die. So it's one of the most important systems and most important for you to learn and manage. The respiratory system helps regulate pH, that by the carbon dioxide in our system. Like I said, CO2 goes up, your pH goes down, you get acidotic. It protects us against inhaled pathogens and irritants, and it helps us vocalize. So here is a picture of the structures we're going to learn about for the most part. I like this because there's extra things we're not going to learn about, but it's pretty much, this is a good overview of what we're going to talk about as far as anatomy. So you've got the upper airway, basically from the larynx up, and trachea down is considered lower airway. A big part of the airway is the thoracic cage. The thoracic cage consists of the ribs, the sternum, the spine, and the diaphragm. That gives your chest a bony structure that supports the breathing and helps provide a negative and positive pressure that makes the air go in and out of your chest. I'll talk about that later, the physiology of the respiratory cycle. The diaphragm is not shown in this picture, but it's a dome-shaped membrane that sits kind of right here. And when it flattens out and comes down, it causes a negative pressure intrathoracically, and air comes into the lungs. And then when it relaxes and comes back up, air gets pushed back out of the lungs. Just another picture of the thoracic cage showing the muscles of inspiration and expiration. So the thoracic cage, the diaphragm moves and causes a breath, but the thoracic cage also moves and causes breath. So when you inspire, the thoracic cage moves up and out, and that causes a negative pressure in the chest and pulls air in through your mouth and nose into your lungs. The muscles that do that are the sternocleidomastoids up here, and the scalenes up there. The external intercostals and the diaphragm are the muscles of inspiration. I, for the longest time, had a hard time remembering. I knew there were intercostals on inspiration and expiration. I couldn't remember if external intercostals were inspiration or expiration, and vice versa for internal. One way to remember it is they're opposite. External for inspiration, internal for expiration. But it's a popular, in anesthesia, that's a popular stump your test question, so I like to tell people how to remember that. And then the muscles of expiration are the internal intercostals and the abdominal muscles.
Are those all accessory muscles or no?
I would say abdominals are accessories, and the sternocleidomastoid and the scalene. The intercostals pretty much work all the time when you breathe. The intercostals and the diaphragm work all the time when you breathe. The other ones are for forced inhalation and exhalation. So talk a little bit about Boyle's law. It basically talks about pressure and volume have an inverse relationship. So as the pressure decreases, the volume is going to increase. or vice versa, increase in volume means lower pressure. Basically, when the pressure drops in your thoracic cavity, the volume's going to increase because it's sucked air down into your lungs. The ribs move up and out, the diaphragm flattens, and the chest volume increases. And then opposite happens, the volume decreases as the pressure gets higher intrathoracically. Your ribs fall, your diaphragm moves up, and it pushes the air out, decreasing the volume in your chest. So Boyle's law is a physiological law. I'm not sure if they talk about that in your book or not, but it's the physical law that describes inspiration and expiration. So the upper airway, again, this one has, I don't think you really need to know about the sinuses, but it's good to know that they're there. We're going to talk about the upper airway here. So the nasal cavity is the superior part of the airway. Inside the nasal cavity, I'm going to talk about this and leave that picture up so you can see. In the nasal cavity, you've got these little lines here. They're actually little bony structures with lots of capillaries in them, big blood flow here. It separates the nasal cavity into 3 different parts. And why it does this is it causes turbulent flow of air to come in and warms the air as it comes in through the nose to go down to the lungs, because you don't want your lungs to get cold air. So those are the turbinates. There's an inferior, middle, and superior turbinate. They also have mucus. That's part of what produces the mucus, and that helps clean the air of debris as you inhale. And then the olfactory nerves are located in here also. That's what produces smell. Olfactory nerve, anyone know what cranial nerve that is?
12?
2.
3.
1.
We would have gotten there eventually, guys.
There's only 12 of them, so. So, the sinuses here, there's several sinuses. They're air-filled cavities. They're mucus-lined, and they, again, just try to help capture trapped bacteria and debris as you inhale. Auditory tubes, I have a hard time saying eustachian tubes. Let's see. They show them, yeah, right here. These are the tubes right here. They go from your nasal cavity to your ears and help regulate pressure in your ears. When your ears pop, that's why. That little thing there. They connect to the middle ear, and they equalize pressure in the eardrum. And then there's the nasal lacrimal ducts. Are they on here? I don't see them on here. Basically, it helps drain tears and debris from the eyes into the nasal cavity. That's why you get stuffed up when you cry. It's probably not many of you that cry in here.
No. Never.
Never. Every night.
Maybe before this test you might. Yeah, after the test.
You're making this test, right?
No, but I have seen the test, and I will talk about everything that's on the test. So the oral cavity, you've got the lips, the teeth, the gums, the hard and soft palate. Hard palate is just this bony structure here. Soft palate is the non-bony structure that forms the palate. You've got the tongue and the cheeks. That basically creates the oral cavity. Let's see. Here's my notes here, see if there's anything special in that. The upper airway can be, or the oral cavity can be an important, it is a huge part of intubation because that's usually the path you're taking to intubate a patient. And you can have trauma and bleeding, swelling in this area that prevent you from even getting down to the airway with a tube or visualization. Also, for whatever reason, people like to pierce things in their mouth, and that can get in your way of intubating. I've seen the uvula pierced, the tongue, lips, yeah. Ugh. So it's there, and you will see it. So be cautious with that.
So you take them out if you have to, right?
If the patient is awake, I have them remove it. If you have time, you can take them out. But if you see it, just be real cautious of it because you can hook your blade on a piercing, or you can cut their lips and cause more bleeding. Just causes more trauma. I make all my patients take out all their facial piercings before I do any anesthesia on them. It's real fun when you have a laboring mom and say, I'm not going to give you an epidural till that tongue ring comes out. Hate me, but.
I mean, do they like put their fingers way down in their throat to get that one out, or how does that work?
How do they get that one out?
I think they
Pliers?
just go down and, I don't know. I don't know how it comes out, but yeah.
So you're not a fan of piercing, is what I'm picking up here.
Well, I'm just going to leave it at that. I don't have any. Then the oral pharynx is behind, it's kind of this area too. It's got the tonsils in it. The uvula hangs down. The oral pharynx is considered the posterior third of the tongue, this little area here. And the nasopharynx is kind of behind, above the soft palate. So you got the nasal pharynx and oral pharynx and larynx right here. Okay, so the word pharynx is Latin. It means a gulf or a chasm or a gap or continuity in a deep fissure or a cleft. So it's just kind of a space, basically. They have dual purposes for respiration and ingestion of food. So it's a spot where stuff can get caught. Let's see. The pharynx is also the location of a lot of muscular activity with coughing, swallowing, and the gag reflex. And then the larynx is right here, the structure, and it is what contains the voice box, basically. It's the connection between the oral pharynx and the trachea is the larynx. I think I have a picture of that. Here we go. Here's the larynx here. So the larynx, this is your intubation anatomy. This is important to know. This is the anterior view, so view like this. And then the posterior view, if you were to look through like this, and then a lateral or a cross-section view. The important things to know are the thyroid cartilage, this right here, your Adam's apple. If you can feel it, if you swallow it, moves up and down. That, you need to learn how to identify that, because this little membrane here is where you're going to cric someone. This is the cricothyroid membrane. So it's between the thyroid cartilage and the cricoid cartilage is the cricothyroid membrane. And that is where you're going to save someone's life if you can't get an airway. Epiglottis is right here. It's the little flap in the airway that closes the airway off as you swallow. It also is the point where you put your blades to intubate people. The curved blade goes behind the epiglottis, and the straight blade lifts the epiglottis up to reveal the vocal cords.
So I'm sorry, you said cricoid cartilage, that's not where we're going, that's just our spot, and then we go up, right there.
You feel for the thyroid cartilage, and between the thyroid cartilage and the cricoid cartilage, you feel a soft little membranous hole, and that's where you're going to poke to do a cric. And we'll talk about that this afternoon.
Oh,
The cricothyroid membrane.
Okay.
I would challenge you to find that on yourselves and on each other and get good. Go home and feel it on your kids and your wives and your husbands. Get good at feeling that. And all sorts of body habit assists. You need to be able to identify that structure. This thyroid cartilage is also the point where you can manipulate the airway or have someone manipulate the airway when you're intubating. You can kind of move the vocal cords down and into view if you're having a hard time viewing the vocal cords. So this is a real, does everyone want to try and feel it right now? Just go ahead and swallow and feel the part that moves, and it's going to be a kind of a hard cartilaginous structure. And then if you rock your finger down, you'll feel that cricothyroid membrane. Mm-hmm. It takes some practice to feel, but
I think they might have, but I don't know.
Let's poke it and find out.
When he's like 10, I can see your life.
do it. Okay. Other important things to know are the cuneiform cartilage and the corniculate cartilage and the arytenoid cartilages. These in general are called the arytenoid cartilages. Or the posterior cartilages is another name for them. I think that's the term your book uses, but I'm not sure. These, right above these cartilages, and I'll show you an actual tissue view of these. You can see these when you intubate. These are landmarks that you're looking for when you're intubating. Right above the arytenoid cartilages are your vocal cords, your target for your tube. So those are important. They can also, there's sites of muscle attachment that cause phonation, that close and open your vocal cords. And they can be damaged with a rough intubation. You can actually disarticulate these things if you're not careful with the airway. And disarticulation of these means the vocal cords can slam shut and then the patient can't breathe and you actually cannot give tube through shut vocal cords. I've tried.
What'd you call them before you called them the posterior cartilages?
There's three of them. There's the cuneiform, the corniculate, and the arytenoid cartilages.
Okay.
And you can call them posterior cartilages, or you can call them arytenoid. Like, a lot of times when you're intubating in the OR, we'll say, do you see the arytenoids? And in the advanced airway, I think is where you'll see pictures of these. In more detail.
Are those the actual vocal cords that you will see?
Nope, they're little pink bumps that you'll see in the airway. And they're symmetrical, so there's three of them in line on each side. And then in between those you'll see the white vocal cords. That's what the muscles in the vocal cords attach to. Okay, another important structure here is the vallecula. So you've got your epiglottis right here that closes over the airway when you swallow. Your curved blade, when you go in to intubate someone, is going to go right in this spot called the vallecula. And there's a ligament there that moves, that supports the vallecula when it moves. You're going to push on that ligament, and it's just going to lift that vallecula up, and you'll see cords. It's amazing. So that's a term to remember. So tracheal cartilages, important to note that in the anterior view, there's tracheal cartilages. You can feel them in most people. Posterior view, though, there's no, they don't completely encompass the trachea. So it should be soft on the posterior view. And I actually felt this in real life this weekend on a bad airway case. My hands were in someone's throat. It's crazy. I'll tell you that story this afternoon. But yeah, the back of that is very smooth. When you're feeling for tracheal rings, then don't. It's scary. So this is just more of a view, anterior and posterior view. They're calling the cricothyroid ligament, the intrinsic ligament here, that is an uncommon term. It's more commonly called the cricothyroid ligament because it's in between the thyroid cartilage and the cricoid cartilage.
So,
And this one's
you
right out
said
of
membrane? You said the
Cricothyroid membrane.
or ligament as well?
Yeah.
Okay.
The hyoid bone of interest, it doesn't really matter for your test, but it's the only bone in the airway, and it does not articulate with any other bone. It just kind of sits there with the cartilages and stuff attached to it. So. Okay. Again, I'm going to leave this picture up while I talk about the anatomy. So the epiglottis is a cartilaginous flap that protects the airway during swallow, right here. It's also the site for your blade, depending on what blade you're using. We talked about the hyoid bone. The thyroid cartilage is, again, the Adam's apple. It moves up and down when you swallow. That movement is because it's attached right here to the epiglottis, and the epiglottis closes and lifts that Adam's apple up. The cricoid cartilage is a complete ring of cartilage. It is the only complete ring that will go posterior. You can see it here. And it's the site of the Selleck maneuver, where you push the airway down to occlude the esophagus during an RSI intubation. Because it's a complete ring, you can push it down and occlude the esophagus. Okay, and then the cricothyroid membrane is for the cric site. We talked about the vallecula, and it's the ligament. You can't see it, you saw it in that other picture. This ligament here is also called the hypoepiglottic ligament, and that's where you put your curved leg for intubations. I know I'm repeating myself here, but I just want to go through all the slides.
So the vallecula is also called, what did you say?
It's in your notes. It's the hypoepiglottic ligament.
Okay.
And then the arytenoid cartilages again are right here. And I should have put in a picture for what you're going to see, but you'll see it later. All right. And then here's a picture of the soft tissues of the airway. Again, you've got the thyroid membrane and the cricoid membrane. Here's the cricothyroid, or I'm sorry, the thyroid cartilage and the cricoid cartilage, cricothyroid membrane. It's important to note that you've got lots of blood flow in the neck. You've got your common carotid and your internal and external jugular veins. And then the green stuff here is lymph tissue, part of the immune system. And then the yellow stuff in here is all the nerves that come off the neck. So lots of structures. This big pink H-shaped thing here is the thyroid gland. It's very close to the point where you do an emergent cric, and you don't want to damage that. It's kind of an important gland. Regulates your metabolism in your body. Okay, I'm going to put this picture back up. The vagus nerve. It doesn't show it on here. The vagus nerve is in here also, so if you're manipulating the neck, it's kind of off to the side. You can cause someone's potential bradycardia. Stimulating the vagus nerve is in here too. So if you're manipulating the neck and you get bradycardia, that's probably why. So this is kind of a hard picture to see. It's just another picture to show the upper respiratory tract versus the lower respiratory tract. We just talked about the upper. Once you get through the larynx and down into the trachea, that defines your lower airway. Once you're in the trachea. So, right here is your vocal cords, right in here. Below that's trachea. You feel all the tracheal rings going down to the carina, where the trachea splits into the right and left main bronchus. The rings that you see here are cartilaginous in the trachea. Once you hit the bronchus, those rings are muscular. They're smooth muscle. They're not cartilaginous. They're smooth muscle, which is important because that is the site of bronchospasm. If people are lungs are irritated, those muscles will clamp down and close off the airway. Also asthmatics, that's where asthma happens, right in here with these muscular rings. Out here in the distal airways, you have the alveoli and alveolar sacs. I've got a better picture of it later. And then you've got, on your left lobe of your lung, you've got two lobes. You've got an upper lobe and a lower lobe. And then on the right, you've got three lobes, upper, middle, and lower. Anyone know why two on the left?
The heart takes over.
Good. There's also lung parenchyma. Okay, so parenchyma is the lung tissue itself, and then you have pleura. You've got the visceral pleura, which is a connective tissue that covers the lung tissue, the lung parenchyma, and then you've got the so that's visceral, and then the parietal pleura attaches to the inside of your rib cage, and they're really smooth, slick surfaces that allow your lungs to move within your chest cavity like this. But you can't see the pleura on here, but it's important to know the different pleura. That's basically everything we just talked about. There's another picture of the lower respiratory tract. So this is just terminology. So there's the trachea and then the primary bronchi, and then every time it branches, it goes to secondary bronchi, tertiary bronchi, and so on. So when pulmonologists are bronching patients, they actually have names for all of these branches. They go down into primary, secondary, tertiary, and so on. Yeah.
So the larynx is part of the lower.
Larynx is upper.
Larynx is the dividing line.
Yeah. Well,
The bottom of the upper? The
Yes.
left part, okay.
Yeah. Yep. Once you're in the trachea, that's the. So larynx is upper, and then once you're in the trachea, past beyond the vocal cords, is when you're in the lower.
Okay. Thank you.
All right. So this is a picture that shows that smooth muscle in the bronchioles. It just wraps around and contracts and expands. And then your little alveoli sacs. And here's a picture of the contracted, irritated airway with mucus in it. You can see there's not a lot of room for airflow in there. And that's what an asthma attack looks like. These muscles squeeze down. They cause turbulent airflow and not a lot of airflow through there. And then the irritation causes secretions also. So the blood flow to the alveoli, you've got your pulmonary artery and pulmonary veins. Artery red, vein blue. They come down and break into little capillaries, like this. And each little alveolus has a huge network of capillaries. Capillaries are single cell walled blood vessels, and that's where the gas exchange happens. So the gas has to diffuse across the single cell wall of the alveoli and also through the single cell wall of the blood capillaries here, and then the gas exchange happens. All of the blood that goes through our body goes through the lungs, unless there's an anomaly in the heart. But that's a huge amount of blood flow that gets distributed throughout the lungs with every heartbeat. So I can't remember the exact number of length or this surface area of capillaries, but it's enormous. So, and there's millions of alveoli in your lungs.
Isn't that like half
Half the blood goes to the body.
Something like that.
40 square.
Something like that, yeah. So, opposite of your tissues, you've got, normally in your tissues, you've got oxygenated blood that comes down and goes to the tissues, and then deoxygenated blood goes back to the heart. It's opposite in the lungs. You've got deoxygenated blood going to the alveoli, picking up oxygen, and then going back to the left side of the heart. It's red. So that's where it's opposite. Your pulmonary artery is actually deoxygenated. Your pulmonary vein is actually oxygenated. Yeah, backwards in the lungs, which makes sense. And then the alveolar sacs contain a substance. There's not a picture of it in here, but it's called surfactant. The surfactant helps to decrease the surface tension. These alveolar sacs are like balloons, and they want to deflate. But the surfactant helps hold that tension and helps hold them open. That's important for people with like cystic fibrosis. That's surfactant, and alpha-1 antitrypsin disease. I think that's the name of it. There's a couple diseases out there where people don't produce surfactant. So it's important if you run into a patient like that, you give them PEEP to hold these alveoli open. If they don't have this surfactant, they're going to have collapsed lungs really easily. Also, preterm infants don't develop surfactant. I think it's until week 32 or 34 in utero that they get surfactant. So if you come on to a preterm delivery, that baby's not going to have, the alveoli are not, it's going to be like blowing up a fresh balloon. It's really hard to get those inflated.
So you use the PEEP, you said?
PEEP, yeah.
Okay, and
PEEP.
then, how do they treat that?
There are surfactants that you can inhale and medications that can help keep those open. There's artificial surfactants.
So they would just do breathing treatments on a daily basis or something?
I think so, yeah. What else is missing here? Trying to make sure I don't miss any test questions in my lecture. Because I didn't write the test. Okay, so more on the blood flow. So deoxygenated blood comes to the right side of the heart, through the right atrium and right ventricle, and then up through the pulmonary artery to the lungs, brings deoxygenated blood to the lungs, goes to the alveoli through the capillary system, gets oxygenated, and comes back through the pulmonary veins into the left atrium, gets pumped to the left ventricle, and out the aorta to the rest of the body, the head and the body. Any questions on that one? Now, sometimes there's anomalies where there's connections between the pulmonary vein and the aorta. So the deoxygenated blood actually goes out the aorta, or the oxygenated blood goes back to the lungs. Is more likely goes from high pressure to low pressure system. And then sometimes there's a connection between the right and left atrium, and rarely there's a little hole between the ventricles, but that's pretty rare. More likely the atrium. So sometimes you're not going to have normal physiology on these patients, and they're going to have either high or low oxygen sats and higher pressures in the lungs. As you can imagine, so the blood pressure coming out of this thing is high, right? The aorta's got a high blood pressure because the left ventricle is pushing up out. And the pulmonary artery is a nice fragile vein. It's a low pressure system. So if you have high pressure connection here in a low pressure system, you're going to have high vascular pressures in the lungs that can make ventilation difficult and oxygenation difficult.
Wouldn't the pulmonary arteries still be under pretty good size pressure with contraction of the right ventricle, or no?
Decent pressure, like we're talking
I mean, it's not fast.
20 to 40 millimeters of mercury pressure in the right-sided system, and then, you know, like 120 over 60 or 80 in the left-sided system. So there's a pretty good pressure difference there.
But it's not,
Yeah.
How do you tell the pressure on the pulmonary arteries?
We have catheters that we can put in. The catheter goes in usually right here, and we thread it down through here, and then it sits right before it branches, and we can monitor pressures there. So there's also ultrasound Doppler flows that they can estimate pressures, but we can direct monitor pressures, which we do in the ICUs and sometimes in the OR, monitor these pressures for like pulmonary hypertension and stuff. That's the pulmonary artery is the site of pulmonary hypertension, and the pressures are high there.
Those are Swan and catheters.
Swan scans, yep. Yep. Okay, so on to pediatric anatomy. This is an important chart for you guys. Kids are not little adults. They actually have anatomical differences. Their tongues are bigger than adults. Their epiglottis is more flattened or omega shaped, and it's extremely floppy, whereas adults have a firm and, pediatrics is more rounded, omega shaped and floppy. Adults are more firm and flatter. The epiglottis level is actually different. It's higher in kids, meaning that their airways, it's going to be a more difficult view to get a visualization of their cords because the airway is actually higher. That's a pretty good difference, 2 levels of the spinal cord.
But the cords are in the same spot?
Nope, they're
moved
going to be moved up. The trachea in a child is smaller and shorter, obviously, because the child's smaller and shorter. But the adult, it's wider and longer. This is important because it's gonna be easy to either, if you have this much room for tube movement in that trachea before you're extubated or before you push the tube down into the right main stem, it's really easy to extubate or main stem a small child because the trachea is so small. How many of you have young kids? Just think about how short their necks are and what that equates to for their trachea length and size. They say the trachea in a child is about the size of their pinky. Just a little bit bigger.
So their pinky or our?
There.
So what are these students?
No, I hope not.
Yeah, I had a partner the other day that used to kind of almost go by
You can, when you're picking size of an ET tube, now do not put this on a test. On a test, they're looking for actual equations, how to figure out an ET tube size. But, like if you're in a crash and you're looking for tubes and don't have time to calculate it, look at the child's pinky and go for a tube that's approximately that size, maybe a little bit smaller.
But there's an actual way to calculate.
They're, yeah. We'll talk about that later. Their cartilages are more flexible because they're still growing. So their trachea is going to be more flexible, and it's because of the flexible cartilage, it can collapse on itself more easily on inspiratory pressure. Whereas adults, we're done growing and our cartilage is nice and firm. The larynx itself is more funnel shaped. It's more anterior and more funnel shaped, which just makes it harder to identify structures. Let's see. Okay, so on a kid, because their airway is up higher, their trachea, it's more of an angle for the trachea to dive down into their lungs. So a lot of times on kids, you can get the breathing tube through the cords, but you have to like really twist it and work it down because it's a steep angle to go down to the trachea from there. Whereas adults, our airway is more in a straight line. The narrowest point, people love this question, the narrowest point of a child's airway is the cricoid cartilage, or the subglottic region, and the narrowest point on an adult is going to be their glottic opening or their vocal cords. And then lung volumes, the maximum lung volume for a newborn is 250 mLs. Obviously, for a neonate, it's going to be smaller, so that's pretty small. That's like a cup, right? 250 mLs. And then an adult, our maximum lung capacity is up to 6 liters. So we don't breathe 6 liters, obviously, with every breath, but if somebody were to inflate our lungs completely, you could fit 6 liters of an adult male.
Just for like clarification, is that a range? Because in the book it said 5,000.
Yeah.
Is it just a?
Yeah, women are going to be smaller, body size is going to be big. Tall people have bigger lung surface area, short people have. So I would say 4 to 6 liters is probably a good average. And here's a picture of the anatomy of an adult. You can see here the narrowest portion is that cricocartilage, and then in an adult, it's right here where the cords are. Their tongue is larger, so their oral pharynx is smaller. Less space to get your blade and more tissue to push away to get a view of the airway. The teeth may or may not be developed in a child. They are under the gums though, so you can cause dental damage even if there's not teeth actually through the gums yet. Airways are smaller, so it's easier to choke on things, easier to lodge things in the airway. Their head size is different. They have a bigger occiput, so if you're laying flat, that big occiput's going to push their head forward and close their airway, versus an adult, you lay flat, your airway's open. So typically how we fix that when we're intubating a patient is just roll the towel and put it under their shoulders to extend their neck a little bit. Just another picture. Their nasal cavity also is less developed, or smaller. The cricothyroid membrane, where you trach a kid, tracheostomies are contraindicated in people under 8 years old because that the structures are so small and the membrane isn't fully developed yet, so you can cause long-term issues on a kid if you poke that. Now, would I consider it if the baby's gonna die? I might try it, but according to all the books and probably in a court of law, it's contraindicated. But if you save someone's life, what the hell, right? Another thing, because their airways are smaller, even just a little bit of mucus is going to clog the airways easier than it would in an adult. And when you're starting out with a small airway, just a little bit of those smooth muscles constricting, bronchoconstriction, or asthma, they're really going to have some serious issues because they're already starting with a small airway. So, some more physics for you. This is Lascelles' law of airway resistance. Basically, it says that the bigger the airway, the less resistance, the better, more laminar flow. The smaller the airway, the more resistance to airflow and the more turbulent flow. So you want nice, laminar, not, low resistance airways to get air down to the alveoli sacs. Any questions on anatomy?
Can you just repeat that?
The bigger the tube, the less.
Is it the same?
It's the same as-
Is it the same with the catheter and the tubing for an IV?
Uh-huh.
Okay.
Yep.
Same law.
Yep.
Okay.
An interesting, I don't think you guys have to know these laws. I had to know them in anesthesia school, but an interesting thing to note with this equation is the radius of the vessel or the tube or whatever is to the fourth power. So, and it's in the denominator. So if your radius decreases by 2, it's actually decreasing by a heck of a lot more than 2. So, it makes a huge difference. Basically, what I want you to get out of this slide is that you should think about, like in a bronchoconstriction or asthmatic patient, why it's so hard to get air in and out is because you're working through little tubes like this. Also, when you intubate a kid on an ambu bag, it might be harder because you're pushing air through a tiny little tube versus like a big, open adult airway. Any other questions? You guys want to take a break now or keep going on the physiology? Break? Break. Okay. How long? Okay.